All right, we're about to begin. Can everybody hear me okay?
Yes, sir.
Yes, sir.
Everybody seen the slide?
Yes, sir.
Yes, sir.
Yes,
All right.
sir.
Okay, so we have completed the trauma module. We're going into the medical emergencies module. Medical emergencies is 10 chapters. All 10 chapters will be on the exam. You are responsible for reviewing 3 chapters on your own. That's chapter 14, 22, and 23. The previous class we covered pharmacology. That's a module by itself. I'll have 2 assignments for that module that will be used as the grade. We'll talk about it. All right, so one of the things that you need to keep in mind with your medical emergencies, and I always tell students that medical emergencies is actually much more difficult to deal with than trauma, because trauma is straightforward. You're controlling bleeding, you're splinting fractures and joints, and you're providing spinal immobilization or spinal motion restriction. It's straightforward, and it gets messy. With medical emergencies, it's not as straightforward because you have patients that present with the typical cardinal signs, and you have patients that will present with atypical signs and symptoms. The ABCs will be important because ABC is important regardless of whether you have a trauma patient or a medical patient. But what is also extremely important to your medical patients is your ability to obtain a sample history, your ability to gather information, whether it's direct or indirect. That's going to be extremely important to your medical patient. All right, so we'll be looking at respiratory emergencies first. So let's get right into it. All right, now patients often complain of dyspnea. Dyspnea is shortness of breath or difficulty breathing. It can be caused by various conditions, right? So a whole heap of things can cause difficulty breathing. So it's going to be challenging, or it can be difficult for you to determine exactly what is going on. But you can't waste time trying to figure out what exactly is going on. You need to manage the patient presentation when it is needed. So let's review the anatomy and physiology. The respiratory system includes all the structures that contribute to breathing. So you have the diaphragm, chest wall muscles, accessory muscles of breathing, and the nerves to the muscles. And the phrenic nerve goes to the diaphragm, the intercostal nerves goes to the intercostal muscles. The upper airway consists of structures above the vocal cords, the nose, mouth, jaw, oral cavity, pharynx, larynx, where we have the vocal cords. And remember that anything above the larynx is upper airway or considered upper airway. Anything below that is considered lower airway. Right? Now, principal function of the lungs is respiration. And when we talk about respiration, we're talking about the exchange of oxygen and carbon dioxide. Air travels through the trachea into the lungs, to the bronchi, which is larger airways, and that divides into the bronchioles. And we have approximately 100 million bronchioles in our lungs. Each bronchioles have 7 alveoli, so we have about 700 million alveoli in the lungs. The alveoli is where the actual exchange of oxygen and carbon dioxide occurs. Now, respiration process, and really what we're looking at here is the process of ventilation. So ventilation involves inspiration and expiration. One phase is active, the other phase is passive. Oxygen is provided to the blood, carbon dioxide is removed, takes place rapidly at level of the alveoli. All of this is review, things that you should know already. In the alveoli, oxygen passes into the capillaries. Carbon dioxide returns to the lungs, and we exhale that. The brainstem senses blood carbon dioxide levels and regulates breathing rate and depth. That's the primary stimulus to breathe, right? So it picks up a increase in carbon dioxide, right? But if it's the primary stimulus, it's not directly picking up the carbon dioxide. It's picking up the carbon dioxide combining with water to form acid, which causes the pH to become more acidic. So that's what the brainstem really picks up, right? Now, if the primary stimulus is not working, then the hypoxic drive takes over, and that functions on low oxygen. Now, pathophysiology. Oxygen exchange can be hindered by conditions in the anatomy of the airway. So it can be something wrong with the structure. It can be a disease process, traumatic conditions, abnormalities in pulmonary vessels. You must be able to recognize the signs and symptoms of inadequate breathing and know what to do about it. Some patients have chronic carbon dioxide retention, and these are the patients that will rely more on their hypoxic drive than their primary stimulus. So we need to be cautious with how we give these patients oxygen, right? Now, if a patient clearly requires oxygen, whether or not you suspect it's the hypoxic drive they are using our primary stimulus, do not deny a patient oxygen if it is needed. All right, now causes of dyspnea. Patients often have dyspnea or hypoxia with pulmonary edema, that's building up in the lungs. There can be some swelling as well. Hay fever, that's a mild allergy or seasonal allergy. Pleural effusion, that's fluid, small amount of fluid accumulating outside of the lungs. Cancer patients can get that. Obstruction of the airway, hyperventilation syndrome, that's a panic attack. Environmental or industrial exposure, drug overdose. All of these conditions can cause difficulty breathing. There can be an issue with gas exchange, right? Whether it's by fluid or the alveoli collapsing, losing its surfactant and collapsing, pus building up, right? Damage to the alveoli, obstructed air passages, obstructed blood flow to the lungs, excess fluid in the pleural space. All of these complications can cause difficulty breathing or dyspnea. Patients may also complain of chest tightness or ear hunger. Common with cardiopulmonary disease, Pain can cause rapid shallow breathing. Breathing deeply causes pain because the chest wall expands. So they can present as if they're having a MI or myocardial infarction. So communication and history is going to be very important. Now, upper or lower airway infection. Infectious disease may affect all parts of the airway. And when you're going through this portion of the slide, you need to have a little section in your notebook to classify for infections that will affect the upper airway and problems that will affect the lower airway, right? So you need to separate them. Some form of obstruction causes dyspnea, mucus and secretions obstructing airflow in major passages. Swelling of soft tissues in the airway can occur. This can cause problem. Impaired exchange of gas in the alveoli. And the first one we're going to look at is croup. So this is inflammation or swelling of the upper airway, right? Common in your pediatric population. It will cause a mild fever because it's a viral issue. So the fever will not be high. The patient can present with stridor, which is high pitch whistling type wheezing sound, right? Because it's common in the pediatric population, it is concerning because their airway anatomy is more easily compromised because of the size of the air passage and structures positioned in the airway. Because regardless of the type of respiratory tract infection, because infections will lead to dehydration, humidified oxygen will help these patients. So we always provide humidified oxygen when we suspect a respiratory tract infection. Do not manipulate the patient's airway, right? So do not manipulate the patient's airway in the field. Once they are communicating with you, don't pause and open the mouth to look inside. None of that, right? We don't do that because that may aggravate the condition and cause further swelling of the ear passage. Then and croup would be upper airway, upper airway issue. Then we have epiglottitis. This is a bacterial infection. So croup is a viral infection. Epiglottitis is a bacterial infection causing inflammation of the epiglottis. Bacteria tend to cause high fever, not mild, high fever. Can occur in the adult population, but it's more concerning for the pediatric population. Children are often found in a tripod position, and the mouth is usually open and they're drooling. Right? Again, this type of patient will benefit from humidified oxygen. Avoid manipulating the patient's ear passage. All right, then you have the respiratory syncytial virus or RSV. Common cause of illnesses in young children. Causes infection in the lungs and passages. Look for signs of dehydration. Anytime a patient has any type of infection, it will lead to dehydration. Treat airway and breathing problems. Patient will benefit from humidified oxygen. And the respiratory syncytial virus can lead to bronchiolitis. So it can cause bronchiolitis in your newborns and toddlers, right? So the younger pediatric population. And once there's itis, you'll get swelling and accumulation of fluid. right? So mentioned that already. The RSV can lead to bronchiolitis, and bronchiolitis in a newborn is really asthma, you know, right? But they don't diagnose it as asthma, right? But think of it as they have asthma with a fever. Right. Then you have pneumonia. This is a bacterial, well, it can be bacterial, it can be viral, but the lung tissue itself is infected, right? Bacterial pneumonia will come on quickly and result in high fever. Viral pneumonia presents more gradually and is less severe. Especially affects people who are chronically ill, right? And usually it is stemming from something, right? Usually they had something before and they're recovering and they develop an infection. Assess temperature and provide airway support and supplemental oxygen. Then we have pertussis or whooping cough. Called, right? So it's an airborne bacterial infection that mostly affects children under 6 years of age, and it is contagious. The patients will be feverish and exhibit a whoop sound after a coughing attack. Watch for dehydration and suction as needed. This is sometimes referred to as the 100-day cough. So they get flu-like symptoms, they don't get better, right? And they start to develop a persistent cough, but it's very unique. So they cough, and immediately after the coughing fit, they have to take a deep breath in. So it's like they cough, and then after the cough, you hear that whooping sound, right? That's pertussis. Now, influenza type A, we are very much familiar with influenza. It became a pandemic in 2009. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. May lead to pneumonia or dehydration. Then we have tuberculosis or TB. This is a bacterial infection that most often affects the lungs. It can remain inactive for years. Patients often complain of fever, coughing, fatigue. Fatigue is common. Night sweats and weight loss, right? Especially in persons that have poor nutrition. Wear gloves, eye protection, and N95 respirator at minimum. Then you have, yes, Miss Nesbitt.
Sir, as EMTs, when we respond, sir, the vaccine that we get in Jamaica will protect us in any way?
A TB vaccine.
Yeah, didn't we get something when we were like a baby?
I'm not sure if a TB vaccine is available here, you know.
I think the BCG has something to do with it. Sorry.
Okay. I'm not sure. I would have to check that out. What I do know is as a EMS provider, I don't know if that is standard in Jamaica, but you have to do a tuberculin skin test, right? Once you're gonna work in the field. And if it's positive, you have to do a chest x-ray to see if the TB is affecting the lungs. But I don't know, man. I'll have to check that out. All right, now acute pulmonary edema. Heart muscle can't circulate blood properly. Fluid builds up within the alveoli and in the lung tissue. Now, even though they're talking about the heart on this slide, one of the most common causes of acute pulmonary edema is going to be the inhalation of chemicals, right? So chemical inhalation causes acute pulmonary edema. Yes, Ms. Dennis?
So I don't know if you had heard me, but I was saying the BCG vaccine that we get when we're babies, that some people get the mark on the
Oh,
hand. That's the
the
one
one
for
that
the
we,
TB.
okay.
Yeah.
Yeah, but are we still giving those though?
Yes, it's still given.
Okay. It's just not leaving the mark anymore, right?
Well, it doesn't leave a mark for everyone.
Yes, Miss Nesbitt.
Sir, and I guess that is why we as Jamaica, we have a positive tuberculin sensitive, the reactive test, sir.
Yes, that could be quite possible. Excuse me. So fluid builds up within the alveoli and in the lung tissue. This is referred to as pulmonary edema. Usually the result of congestive heart failure. And which side of the heart failing would cause fluid to accumulate in the lungs? Rowan. You there, Rowan? Your mic not working, type the answer. Miss Dennis, which side of the heart feeling would cause fluid to accumulate in the lungs?
Sir,
What was that, the left side?
sir,
You're chipping in and out, but I think you said
Sir,
left side.
sir.
hear me now, sir?
Yes.
I was saying the left side, but when I clicked on the microphone, it wasn't working properly.
Okay.
Yeah.
All right. So the left side would be correct. Mhm. Now, once there is fluid building up in the alveoli, that will affect gas exchange. So the gas exchange cannot occur effectively. All right, now chronic obstructive pulmonary disease. It is a slow process of dilation and disruption of the airways and the alveoli, right? And when a patient has COPD, they can either have emphysema, chronic emphysema, or chronic bronchitis, or they have a combination of both. Now, if it's the chronic emphysema, the issue is with the alveoli. So if it's emphysema, it is an alveoli issue where the surfactant that allows the alveoli to have elasticity is removed. And when that is removed, it becomes stiff and it don't recoil properly. So the patient traps air. The patient can trap air inside of the lungs. Now, as a result of that, the patient will develop what we call pursed lips breathing or fish breathing. So they breathe to create a pressure inside of the lungs to open up the alveoli. Now, think about it practically. If I am a patient that, if I am a person that has issues with my alveoli staying open and I have to breathe with pursed lips, just think about trying to blow through a straw, right? Wouldn't that patient require a lot of energy? Most certainly. So the patient is going to use up a lot of energy. So they tend to be very slim, right? We call them pink puffers. They get slim, and because the alveoli doesn't recoil properly, they start to develop what we call a barrel chest, right? So the size of their chest increases. But I don't mean it increase with muscle. You're basically seeing skin and bones, but it's a barrel-shaped chest, right? Now, one of the things that their body will also try to do is create more red blood cells, right? So their blood can become thick over time, and it can put strain on the right side of their heart. So that's emphysema. Emphysema affects the alveoli, right? The chronic bronchitis, right? Chronic bronchitis, that's chronic inflammation of the bronchi, right? Or small or ear passage. So the problem is there's inflammation in that area, and when you have inflammation, you have swelling, you have mucus production, right? With that swelling and mucus production, the ear passage becomes narrow. So when they breathe in, it can open up, but when they breathe out, it can pinch shut because of the mucus and the swelling that is in the area. So not all of the oxygen, sorry, not all of the CO2 is being removed from the alveoli, right? So these patients will have less energy available. Now think about it practically. If I have chronic bronchitis and I am not removing CO2 effectively from my lungs, I will have less energy. If I have less energy available, I will move around less. So they tend to not move around a lot. They put on weight. They tend to be overweight, right? Chronic bronchitis patient. And of course, they're gonna have cyanosis, right? We call them blue bloaters. Now, because of that mucus building up, naturally they're gonna develop a cough to clear that. So they will have a productive cough, right? And it might be active every 3 months for a period of years, right? And just like the emphysema patient, eventually they can have right side heart failure complications. And that would be your chronic bronchitis patient. So chronic obstructive pulmonary disease. It's a slow process of dilation and disruption of the airways and the alveoli. If it's the airway, it is chronic bronchitis. If it's the alveoli, it's emphysema. Caused by chronic bronchial obstruction, may be the result of lung and airway damage from infection or inhalation of toxic gases. But one of the common causes is going to be smoking for many years. So emphysema is the most common type of COPD. Loss of elastic material in the lungs. Causes include inflamed airways, smoking. Most patients with COPD have elements of both chronic bronchitis and emphysema. Right? So that's the ear trapping right there. Right? This is the ear trapping, and the alveoli doesn't recoil properly. Now, patients with pulmonary edema will have wet lung sounds. Patients with COPD will have dry lung sounds. Can be easily confused with congestive heart failure. And again, history and your ability to analyze patient presentation is going to be very important. All right, now asthma, hay fever, and anaphylaxis. Result of allergic reaction to inhaled, ingested, or injected substances. It can also be something that was absorbed. In some cases, allergen cannot be identified. In some cases, there is identifiable allergen. All right. Now, asthma, also referred to as a reactive airway disease, and the system that is really at work here, so it's really the immune system, right? So asthma is acute spasm of smaller air passages, the bronchioles. And there are three things that will occur when your patient has having a asthma attack. They get bronchoconstriction, right? So they are exposed to an allergen, whatever that trigger is, or it can be an emotional trigger as well. They get bronchoconstriction, so the ear passage is constricted. They get inflammation or swelling, right? Edema, and they get mucus production. So it's three things: bronchoconstriction, swelling or edema, and mucus production. And these are the three things that must be managed, not by us necessarily, but in the hospital setting. All right. Now, death from asthma is very common in our pediatric population, right? The death rate is very high. And I would say it's a bit high too in the adult population. And one of the reasons why it's so high in the pediatric population is the patient and family members sometimes misjudge the symptoms. They sometimes misjudge the symptoms. The second reason why the death rate is so high is the clinicians sometimes misjudge the symptoms and don't provide management as soon as possible, right? Now, if you cannot get air into your ear passage, so when the bronchioles become constricted, again, air can enter in, but it's gonna have a hard time coming out, right? Now, if they can still move the air out, it means they are move some amount of air out. It means they are able to get rid of the carbon dioxide, right? But because it's narrow, there is not the air passage become narrow. When they are breathing out, there is a vibration that is created, right? And that vibration is wheezing. Now, wheezing doesn't mean that the patient have asthma. However, an asthmatic can wheeze and they cannot as well. And if a patient is having an asthma attack, a severe attack, and they're not wheezing, they're probably in trouble at that point, right? Because if they get to the point that the ear passage is too constricted or too swollen, or there is a mucus plug there, and they are not able to get the air out, carbon dioxide will accumulate in the body. You don't want carbon dioxide accumulating in the blood because it acts as a narcotic. It is a powerful narcotic. It's going to shut down the brain. And if the brain shut down, the patient's ability to breathe goes with it, right? And the pediatric population, they will compensate a bit longer than the adult. They decompensate extremely fast. And one of the common causes of cardiac arrest in the pediatric population is going to be airway problems. Now, asthma affects all ages, most prevalent in children between 5 and 17 years, produces a characteristic wheezing, and it's wheezing on expiration. So it's wheezing on expiration. Wheezing on expiration is more associated with infectious issues or conditions. Asthma attack may be caused by allergic reactions to foods or allergens or severe emotional distress, exercise, and respiratory infections. Right, so that's your asthma patient. And well, I'll talk about that when we do treatment. Now, hay fever is really a mild allergy, and it's seasonal. Hay fever causes cold-like symptoms. Allergens include pollen, dust, dust mites, and pet dander. The anaphylactic reaction now. This is a severe allergic reaction that affects two vital areas in the body. It affects the respiratory system and it affects the cardiovascular system, right? So a patient having anaphylactic reaction is producing histamine systemically, and histamine systemically causes the air passage to constrict. It causes bronchoconstriction, and it causes the blood vessels, smaller blood vessels, to vasodilate, and that's not good, right? So the patient can't breathe and they're not getting sufficient blood circulation because the blood vessels are too dilated. That can kill a patient and kill a patient very quickly, right? The frontline treatment for anaphylaxis is epinephrine. That is the frontline treatment. Oxygen and antihistamines can be given after epi. All right, spontaneous pneumothorax. Pneumothorax is accumulation of air in the pleural space. It is most often caused by trauma, but it can be caused by medical conditions. So let's say you have a COPD patient who has had this for years. A COPD patient can one day get a joke, and the joke sweet him so much and laugh, and the lining to his pleural membrane ruptures, and then him suddenly can start to have difficulty breathing. That's a spontaneous pneumothorax. And believe it or not, I had a patient just like that, right? He was got a joke, the joke sweet him, having chronic respiratory problems, and it ruptured. The lining ruptured. Now, they also say that it's common in persons that are very tall and or skinny. I'm not sure about the pathology behind that, but it's common. No, yes, Miss Nesbitt.
What if a situation occurs where the alveoli they start bursting up in these COPD patients? Since they have lost their elasticity, could something happen that causes the alveoli to burst up and it causes a spontaneous pneumothorax?
Because it's ear, they have ear trapping, right? So the laughing or the outburst may have caused an increased pressure in an alveoli that already has air in it, and that can cause rupturing, yeah, and a pneumothorax develops. Now, that's one of the things that you have to keep in mind if you have a chronic COPD patient, a patient that has had it for many years, or a chronic asthmatic patient that you're providing positive pressure ventilation for. So if they've had it for many years, meaning they're at the end stage, where you can feel resistance, and you will feel resistance, right? When you position your airway and you squeeze in the bag, you're gonna feel the resistance in your lungs. You're gonna feel that back pressure. If you're feeling resistance, you need to ventilate them much slower than you would a normal adult. So let's say I would ventilate an adult at 1 breath every 5 to 6 seconds. If I have a COPD or asthmatic with increased lung resistance, I would ventilate at 1 breath every 10 to 15 seconds, right? Or you will be guided by your protocol, because if the pressure is coming too fast, it can cause rupture and they can get a pneumothorax, right? So occurs with lung infections or in weak lungs. Patient becomes dyspneic, breath sounds may be absent on the affected side. And these patients, you need to monitor them, right? So if you suspect a spontaneous pneumothorax, you monitor them so that if they're starting to develop a tension, which is obstructive shock, you pick it up early. So lung sounds are gonna be extremely important. All right, pleural effusion, collection of fluid outside the lung, compressed lung, and cause dyspnea. Can stem from irritation, can be caused by infection, congestive heart failure, or cancer. Upright position eases pain, and they usually get pleuric chest pain. That's pain on inspiration. Obstruction of the airway. Patient with dyspnea may have mechanical obstruction, right? Now, when you have a patient having difficulty breathing, two things you want to look for early. Is it an airway obstruction? Is it a pneumothorax? You want to kind of eliminate those as quickly as possible. So patient with dyspnea may have mechanical obstruction. Treat quickly. In unconscious patients, obstruction may be caused by aspiration of vomitus or tongue blocking the airway. If the patient was eating just before this, always consider a foreign body airway obstruction. All right, pulmonary embolism. This is a blood clot that circulates through the venous system. And one of the most common places for it to come from is going to be the lower extremities or the pelvis. All right, patient is usually stationary. One of the common situation is a patient recovering from orthopedic surgery, right? So a clot is formed either in the lower extremity or the pelvis, the venous system, and it travels until it enters the right side of the heart and goes up into the pulmonary artery. It can block the left or right, or it can block both. If it blocks both, which is a sudden embolus, that patient is going to collapse immediately. So if it blocks both sides, immediately that patient is going to collapse and go into cardiac arrest. If one side is blocked, the patient will develop obstructive shock. They're going to have difficulty breathing. They're going to be coughing up mucus with a pinkish color because of that back pressure that's building up, right? And you must be able to pick that up early. A blood clot that circulates the venous system, circulation cut off partially or completely, significantly decreases blood flow. If large enough, it can cause sudden death. And there's a rhythm that it can cause on the ECG or cardiac monitor. It's called a PEA, pulseless electrical activity. Now, signs and symptoms. Difficulty breathing, tachycardia, tachypnea, varying degrees of hypoxia. They will have cyanosis. And with some of these patients, regardless of how much oxygen they're getting, the cyanosis might not clear up because there is a block. They will have acute chest pain, and they will have hemoptysis. So they are coughing up blood. Now, hyperventilation or panic attack. This is overbreathing to the point that arterial carbon dioxide falls below what we would consider normal levels. May be indicator of a life-threatening illness, right? So it doesn't necessarily might be a panic attack. It could be that the patient is compensating for a metabolic state of acidosis, right? So the patient could be compensating for metabolic acidosis. That's why they're breathing so fast, like a patient with diabetic ketoacidosis or a patient with a form of aspirin acidosis, right? But if it's not a compensating mechanism, then it's a panic attack. So can result in alkalosis because they're breathing off the CO2, right? Buildup of excess base in body fluids can cause symptoms, and the symptoms are anxiety, dizziness. They'll get numbness in the extremities. They'll get a tingling sensation. They can start to get spasms in the hands and feet. And if they are not able to control their breathing, they're gonna pass out. All right, now environmental industrial exposure. So pesticides, cleaning solutions, chemicals, chlorine and other gases can be released. Carbon monoxide, odorless, highly poisonous, produced by fuel burning appliances and smoke. With industrial chemicals or solutions, the most important thing for you to remember is to protect yourself and your partner, right? Don't put yourself at risk. That's the most important, right? So you must have an established hot zone, warm zone, and cold zone. And your responsibility to treat will be in the cold zone. Let the hazmat technicians and specialists function in the hot and warm zone. The warm zone would be where the patient is decontaminated. All right. Now let's look at the patient assessment for respiratory emergencies. So we will do our scene size up, ensure that the scene is safe, take the necessary standard precaution, consider the possibility of infectious disease or toxic substances. So if you're considering the possibility of infectious disease or toxic substances, you need to use extra precautions, right? So if you need to put on your N95, you need to get that on, right? You have to protect yourself. If you need to create distance between you and the scene because you suspect toxic substance, do so. If it's a hazardous material situation, you should be so far that you need your binoculars to see the location. You will consider mechanism of injury or nature of illness. If in question asked why 911 was activated, question the patient, family, or bystanders to determine the NOI. Primary assessment. Identify immediate life threats, form your general impression of the patient and the environment, note the age and position of the patient. And at this stage, I'm not trying to ascertain the exact age of the patient. I'm trying to put the patient in an age category. Is it an adult? Is it a pediatric? Is it a geriatric patient? Use your AVPU scale. Ask the patient about chief complaint. Assess airway and breathing. Make sure airway is patent and adequate. Assess rate, rhythm, and quality, right? And you definitely need to look at depth. Ask the following questions. Is the air going in? Does the chest rise and fall with each breath? Is the rate adequate for the victim's age? No, there is something that you must learn, and you need to learn it now if you have not learned it before, right? You will cover many emergencies, whether it's medical or trauma within this course, right? It is very difficult to remember every emergency because you can get a asthmatic patient today and get one tomorrow, and the presentation is not the same. So what you have to focus on is the fundamentals, right? The fundamental concepts, the cardinal signs, and patient presentation. So there are 6 patient presentations that you must anticipate when you go in the field, right? So your patient can present 6 ways. The patient can be responsive. So you can have a responsive patient. You can have a semi-responsive patient, and you can have an unresponsive patient, right? Now, the semi-responsive patient has 2 possible presentations. If a patient is semi-responsive, they will present semi-responsive with good chest rise or semi-responsive with poor chest rise. I hope you're getting that, So the first presentation is responsive. Your patient can also be semi-responsive, but when they are semi-responsive, is either they have good chest rise, which you just need to supplement with O2, high or low, or they have poor chest rise, which means you need to create ventilations for them, right? The other way the patient can present is unresponsive. So a patient can present unresponsive. And when they are unresponsive, it is 3 possible presentations. The patient can be unresponsive with good or visible chest rise. The patient can be unresponsive with poor or no chest rise, but they have a pulse. So that's unresponsive with good chest rise, unresponsive with poor or no chest rise, but a pulse is present. And the unresponsive patient can be unresponsive, no chest rise, no pulse. These are the 6 patient presentations that you must have a primary assessment approach for. That's what you need to SWOT. So you need to know to manage these 6 patient presentations, regardless of whether it's a medical or trauma patient. That's how your patient is going to present. So when you approach your patient and you conduct or ascertain the patient's level of consciousness, you should know what type of patient you have. Is this a responsive patient? Is it a semi-responsive patient with good chest rise or poor chest rise? Is it an unresponsive patient with good chest rise, poor chest rise, or no chest rise, but a pulse is present? Or is this a patient that is unresponsive, no breathing, no pulse? That's what you need to learn. That is my words of wisdom. Use it as you wish. All right, now, primary assessment. Make sure the airway is patent and adequate. Assess rate, rhythm, and quality. Ask the following questions to yourself. Is air going in? Does the chest rise and fall with each breath? Is the rate adequate for the victim's age? Assess breath sounds, right? So once you suspect that your patient is having a breathing issue, listen to the patient lungs, right? The purpose of listening to the lungs is to determine if your patient will require more than oxygen. So you should not be listening to a patient lungs and they are not on oxygen if they need it, right? We don't listen to the lungs to determine if patient needs oxygen. We listen to determine if the patient needs more than oxygen. So assess breath sounds, check breath sounds on the right and left side. So you always compare right side to left side. So it's not apex and then base. It is apex on the right, apex on the left. Always compare bilaterally. Now, abnormal lung sounds include wheezing, that's bronchoconstriction, rales, that's fluid, rhonchi, that's pus or mucus in the alveoli, stridor, that's upper airway issues. Circulation, evaluate for shock and bleeding. Assess capillary refill in infants and children. Assess perfusion by evaluating skin color, temperature, and condition. Reassess life threats. Transport decision. If condition is unstable and there is possible life threats, address the life threats and proceed with rapid transport once a patient is critical. After the primary taking, investigate the chief complaint, right? Objective and subjective observation, report pertinent negatives, find out what the patient has done for the breathing problem, because sometimes they have medications at home. Sample history, important. OPQRST assessment, you might not ask all of the letters in the OPQRST unless the patient is having pain, right? You're gonna use the PACE acronym, right? So this is a new one. I'm not a big fan of acronym. I believe if you do a thorough assessment and ask the right questions, you cover all of these things, but they want you to learn it. So go right ahead, right? Go right ahead. So the PACE acronym, progression associated with chest pain, sputum, talking, tiredness, exercise tolerance. That's what the PACE acronym represents. Your secondary assessment, more in-depth assessment of the body system. So you're looking at respiratory and cardiac. Those systems are closely linked. So if it's a respiratory problem, you definitely need to look at the cardiovascular system, pay attention to the skin, monitor the blood pressure, monitor the patient's level of consciousness or neurologic status. Proceed only after addressing life threats. Look for signs of COPD, very important slide. Patient older than 50 years of age, history of lung problems, right? Active smoker or former smoker, tightness in the chest, constant fatigue, hair-like appearance to the chest, the use of accessory muscles, abnormal breath sounds. In your reassessment, repeat your primary, right? Look at your intervention. Oxygen via non-rebreathing mask at 15 liters. Is it working? Is the patient getting better? Do I need to step up to something aggressive like positive pressure ventilation? These are things that you need to be thinking about. Do I need to consider medication administration? Airway management techniques, position in high Fowler's position or position of choice, right? And once a patient is conscious and having breathing problems, rarely, if ever, you will see them lying down. If them lying down, they might be in trouble. They're usually upright. So we try to keep them in that position, right? Assisting with respiratory medications, you'll be guided by your medical control and your protocols. My slide is not moving forward. I think I'm about to lose connection. Can you hear me?
Yes, sir.
Yes, sir.
All right, so take a break. We will start back at 10 minutes past 5 because I'm gonna have to log out and log back in. So take a break, 10 minutes past 5, we will resume.